Let's start. ALI, acute lung injury, and ARDS, acute respiratory distress syndrome. So the synopsis is definition, etiology, pathogenesis, morphology, clinical features, and summary. So first let's start acute lung injury or ALI. So ALI stands for acute lung injury and it is characterized by three main points. That is abrupt onset of hypoxia. Hypoxia comes in quickly. Then bilateral pulmonary edema. There is edema in both the left and the right lungs. Then there is no cardiac failure. Cardiac failure is absent. Hence we can say acute lung injury is also a non-cardiogenic pulmonary edema. Now, what is ARDS and what's the difference between ARDS and ALI? Actually, ARDS is a manifestation of ALI. Both lead to alveolar damage, diffuse alveolar damage. Now, etiology. Etiology is, now there are a lot of etiologies regarding ARDS, but the main etiology can be remembered by this mnemonic, that is VPAS headmaster. So, VP for viral pneumonia, A for aspiration, S for sepsis, H for head trauma, and M for miliary TB. Now the other etiologies can include infection like sepsis, diffuse pulmonary infections, viral infections. Then physical can be mechanical trauma, pulmonary contusions, near drowning, fractures with fat embolism, burns, then irritants, chemical injury, etc. Anything that can activate the neutrophils and endothelium is technically a etiology for ARDS. So now what's the pathogenesis? How does this happen? Now, first of all, the irritants and the etiological factors, all these etiological factors, they will come and activate the endothelium. Now the endothelium activation is sensed by macrophages. The macrophages will release certain inflammatory mediators, for example, tumor necrosis factor. This tumor necrosis factor will activate the endothelium further and it will cause the endothelium to become more adhesive. So, by the expression of adhesion molecules, increased expression of adhesion molecules, so the endothelium, as you see, will become activated. Now, the activated endothelium will attract more and more neutrophils. So, that's the second stage, that is the adhesion and extravasation of the neutrophils. The neutrophils will adhere to the endothelium and then they will extravasate to the interstitial space and then they will go to the alveoli. In the alveoli, the activated neutrophils will secrete cytokines, reactive oxygen species and proteases. Along with the neutrophils, due to extravasation, the fluid will also come out. That is the accumulation of intraalveolar fluid and interstitial fluid. This causes interstitial as well as intraalveolar edema. Now the inflammatory mediators that are released by the neutrophils will cause alveolar wall damage. That is the type 1 and type 2 cells will become damaged. So this, as you see, this is the necrotic type 1 cells. Now the edema fluid contains mainly fibrin. That fibrin in the edema fluid and the necrotic debris from the type 1 cells both will combine to form a hyaline membrane. That's the last stage, the second last stage, formation of hyaline membrane. After that, this forms a granulation tissue and that injury will resolve. So resolution of the injury, we will discuss that later in morphology. So this is the pathogenesis. So the endothelial activation is sensed by macrophages releasing inflammatory mediators. The inflammatory mediators will activate the endothelium to become more adhesive and the neutrophils will adhere and extravasate to the alveoli along with the fluid which causes interstitial and intraalveolar edema. The neutrophil will release ROS, cytokines and proteases which damages the alveolar wall and forms a hyaline membrane. So the morphology. First stage is acute exudative stage, in which the exudates, the interstitial edema is formed. So we can divide that into lungs and the alveoli. The lungs will be firm, heavy, red, baggy, congested, and interstitial and intraalveolar edema will be found. Then there will be fibrin deposits. But if you take the alveoli, both ALI and ARDS will lead to diffuse alveolar damage. And there will be a waxy hyaline membrane, as you see in here. There's a waxy hyaline membrane. The waxy hyaline membrane is formed by fibrin-rich edemal fluid and remnants of necrotic cells. As you can see, remnants of the necrotic cells and the fibrin from the edemal fluid. Next, stage 2 is proliferative or organizing phase. In this, the type 2 pneumocyte will proliferate and the granulation tissue will be formed. In most of the cases, the granulation tissue will resolve, but sometimes this can thicken and the fibrin deposit will increase and lead to stage 3, that is late fibrotic stage, in which there is granulation tissue thickening and more fibrin deposition. Now let's take a look at the clinical features. Clinical features are obviously due to ARDS, even though there is type 2 pneumocytes increase, there will be production of dysfunctional surfactant. So there will be lung stiffness. So there will be profound dyspnea, acute respiratory distress syndrome. It's there in the name, distress syndrome. Then there will be tachypnea, increased respiratory failure, hypoxia. The hypoxia obviously will lead to cyanosis. Then you will find bilateral infiltrates on radiological examination. Now you see the chest X-ray of an ARDS patient. This is the normal patient, and this is the patient affected with ARDS. This is actually a very big topic and very deep. Only experienced people can recognize the change. This is actually the change after a few hours have passed, a few days have passed, I think. That's why there's a clear distinction. But sometimes ARDS can be indistinguishable from the normal person. Thank you.